talk on CVI, or Cerebral Visual Impairment Assessment, and early intervention. Over to you, sir.
Good afternoon, and not very nice to be the last speaker for the session, and that too just before lunch, or I think we have just crossed the lunch time. So I'll not take too much of time explaining the evaluation, because Rashmi has done a fantastic job talking about evaluation. Basically, I'll go through what cortical visual impairment is, because most of us are confused about what cortical visual impairment is. It's something like this, where we are going down the cave and we don't know what exactly the problem is. The eye is fine, everything looks good, but then we don't know where the problem is. So, a few examples where we find cortical visual impairment. 2-year, 4-month-old ischemic changes in the cortex with both white and deep gray matter, diffuse abnormalities, cerebral palsy, spastic quadriplegic, seizures since birth, has infantile spasms. Case number 2, 2-year, 5-month-old female child picks up toys, increased facial expressions, no change in mobility, feeding improving, eye health unremarkable, exotropia, onset after head trauma, all milestones delayed. This is something which we discount quite a lot, which is shaken baby syndrome. A lot of shaken baby syndromes are seen in the West. They're diagnosed, but then unfortunately in India it goes unnoticed. Case number 3, 6-month-old female, vision problem noted at the age of 8 months of age, optic nerve head dysplasia, hypoplasia, nystagmus, VEP, all results are delayed, peak poorly performed but consistent with optic nerve hypoplasia, nystagmus, intermittent seizures, poor hand-eye coordination. So these are the cases that we come across when we talk of cortical visual impairment. What exactly is cortical visual impairment? It's a decreased visual response due to neurological problem affecting the vision part of the brain. The eye may be perfectly normal, there's no problem with the eye. You do a complete examination, invariably the eye is normal. But when you do the MRI, when you go through the history, you see that there are problems. So they display very characteristic behaviors. And one of the most frequent causes of visual impairment in children from developed countries. So they show abnormal visual responses that cannot be attributed to the eyes. Brain dysfunction must explain abnormal visual responses. Fixation and the following is not very good. And visual regard to the reach of the child, that is not good. So the common causes for cortical visual impairment: hypoxic ischemic encephalopathy, which is HIE, periventricular leukomalacia in preterm kids, traumatic brain injury due to shaken baby syndrome, neonatal hypoglycemia, metabolic disorders, and the other causes can be antenatal drug abuse by the mother, cardiac arrest, twin pregnancy, central nervous system developmental disorders, or accompanying features of CVI include cerebral palsy and developmental delays. The most common symptoms in CVI are abnormal light response. They either gaze too much at the light or have photophobia. No response to even, possibly not even to strong light. Blunted or avoided social gaze. You don't know if they're really having a social smile, not having. So brief fixations. Intermittent following. You feel that the child is following, fixating and following. It may not be the next time you see the child. Poor visual acuity and poor visual field losses, which is generalized constriction of the visual field, which can possibly not be attributed to the defect that you're seeing. Some of the behaviors that we see with children with CVI: variable or inconsistent visual responses to the same stimuli. You show a stimuli and the response is different every time you see. Better responses to familiar than novel stimuli. Fatiguing with visual tasks. Peripheral visual dominates when reaching. So it is more of the periphery which is dominating. So when the child is trying to reach, he may be looking somewhere but trying to reach out in the periphery. Colored stimuli elicit better responses than black and white stimuli. Visual attention for moving stimuli is better than static stimuli. vision for navigation is unexpectedly good. The parents come and say that the child is able to move across the house perfectly well. And when you check the visual acuity, when you check the vision as such, you feel that the child is not able to see. But when they are navigating, at least in the known surroundings, they are very good. Difficulty seeing an object or image in crowded area. There is figure ground perception. So if it's this entire crowd, they will have a lot of difficulty where it is a solo empty areas. Reduced responses to visual stimuli when music, voices, etc. are there. So they cut off when they are when they are hearing something, when they are smelling something, they cut off the visual responses. Statokinetic dissociation in children. This is something where the child cuts himself off when the static thing is there, but when the moving objects are there, moving stimuli are there, they are very good. So when it is in the periphery is pretty well developed, but the central vision, the parvocellular vision, that is very poorly developed. Other thing that we get confused with cortical visual impairment is delayed visual maturation. So there are 4 types of delayed visual maturation. Type 1 is visually impaired infants, where improved visual ability improves around 6 months of age. Type 2, they have attention problems. Type 3, they have nystagmus or things like that, which decrease the visual acuities. And type 4 associated with retinal, optic nerve, and macular anomalies. Now, what do we do? We do a complete examination, like what my previous speaker has spoken about. A complete ocular examination has to be performed, and then obviously that has to be collaborated with the MRI findings and the electrodiagnostic findings, which work along with the neurologist. What I like to tell my patients or my parents first is mother talking to the child. The child is used to the mother. The child is never used to the father or anyone else, because in the womb the child was hearing, the fetus was hearing all the noises, all the things that was happening with the mother. And mother is the best person who can provide the best possible therapy to the child. So I only tell the mother to hold the child like this, put a big bindi, wear very bright clothes. Like I said, they respond better to color surroundings, colors. So put a big bindi and keep talking to the child. He or she may not be even able to see that, but then talk to the child, and that works as the best therapy that can be provided. And we have seen phenomenal changes when the mothers have done that, and I would always tell any mother to do that, because the child is used to the sounds and everything that the warmth of the mother, and just hold the baby like this and keep talking. Other thing, I'll just go in a quick way. First thing we're talking in terms of is light stimulation. So stimulate using LED lights, bright lights, in a static fashion. Don't make too much of a fast movement. Do it very slowly. Keep on stimulating the child, and over a period of time, use patterns something like these, which can be projected on the screen. It could also be given in single. These are multiple patterns that I'm showing. So project them on screen, or maybe make big cardboards, etc. You show the child and slowly, very, very slowly move. Over a period of time, make these patterns more intricate, introduce colors in that. We generally look at red and green color, basically looking at 2 different spectra. And we also introduce videos, very slow moving videos over a period of time, and make it more and more intricate. As they improve, introduce something like these, the pegboards. So make the movement small, very limited movement, and as the ability improves, increase the color in that, increase the light in that, increase the speed of the target, and over a period of time, the child will be able to do the things properly. And once they are able to do that, then you can introduce computer programs wherein different targets can be projected, different size targets can be projected, the speed with which the target is moving can be changed, And once they are able to do that, then you can start working on more and more binocular aspects. You can work on monocularly improving the visual abilities of the child. And once the visual abilities monocularly improve, you can start working on the binocular abilities. And once you're able to do that, in a number of cases we have seen that the child has improved considerably. And if not, you can also try low vision devices. You can also try prisms, wherein we are using more like Elipelli prisms and things like that, where they help the child considerably. The last thing that we like to do is binasal, because that improves the peripheral fusion. So if there's a refractive error, obviously you're going to correct appropriately and provide binasal, because that improves the peripheral fusion for the child. And along with that, you start providing a lot of stimulation, and that helps the child a lot. Any questions? Happy to take. That we are giving it for squint. In these cases, we are only trying to improve the periphery, because periphery not in the form of an occluded, but we give the stigma, and that can continue for quite a long time till the time the functions improve. So I don't have any specific time duration for which I can tell you, but as the functions improve, we can keep cutting down. And because
Child will withstand the duration of this evaluation in your OPD. Okay, before you are telling them or instructing them we have to put drops and do retinoscopy, just ask the mother that it will take this much time. It might take 3 hours, 4 hours. Will you be able to manage the child? Okay, because to manage a normal child itself is a task, and it's a Herculean task to manage such special kids. Okay, many of you might not be having kids now. When you have kids, you will understand that. So that is one thing that we need to do. If they are okay with that, let them come another day fresh. And you never know at what time the child is alert and active. Only the caretaker who is taking care of the child would know. Sometimes the child will be having a totally opposite sleep rhythm. He will be sleeping more in the morning and will be alert more at the during the evening hours and all. So that is one point as both as ophthalmologists and as well as optometrists that you should keep in your mind.
So I'd just like to add to what he just mentioned. One thing we like to split our evaluation into multiple sessions. Never take too much of time. Secondly, you're not only treating the child, you're also working on the parents, because there's a huge amount of psychology which is involved over here. It's a big shock to a parent when he gets to know that the child is not able to see, and you're working on both the sides, the child as well as the parents, and you have to keep working psychologically on the parent and clinically on the child.
Thank you, sir.
Thank you very much.